Thanks for that introduction. I think this is a fantastic event so far. I wasn't sure what to expect. I haven't heard many of these speakers before, and I've been taking notes, and I'm just super excited to take what I've learned already and go back to my personal finances and my business finances and implement some of these things. As far as following the sleep presentation, I'm over there shaking my head, and it was all I could do not to just want to add to that conversation, because that is the other division of my company is sleep medicine. And so I work really closely with Sleep Group Solutions, and am just super excited to be at an event with them where we can kind of show you how our two companies together can solve that solution. But I'm here to talk to you about medical billing. So my name is Crystal May. I am the COO of DevDent, and I'm from Idaho. So this is a little ways from home, and I have three wonderful children, but I want to put some perspective on how I know what I know and why I do what I do. I started in medicine about 19 years ago, and I did certified coding and billing courses, and I started billing medical insurance for all different medical procedures. I was billing for OB and ophthalmology, general surgery, and I loved it, but I really wanted to get into dentistry. In Utah, where I was living at the time, you do not have to be a dentist to own a dental practice. And so I had this opportunity a little over 15 years ago to buy a dental practice. And within the first 2 or 3 months, maybe even less, I started seeing cases that were medically necessary. I saw patients that were getting dental treatment and getting, at the time, about $1,000 of dental benefits. And I'm going, this isn't right. I know better. I know medical will cover this. So we started billing medical insurance in our dental practice for these everyday dental procedures. And we were getting paid. So I'm like, this is great. We had such success. We started getting referrals from local surgeons specifically. So trauma surgeons. Patients were seeing them for some sort of accident that was affecting the oral cavity. They would do some sort of sinus repair, and then they would send them to us. And we were the only dental office that was really billing medical at the time. So I had these patients handed to me on a silver platter, ready to go. They'd already met their deductibles. Many of them already met their out-of-pocket maximums because they had surgeries of some kind. And their dental treatment was being paid 100% by their medical insurance because we were willing to do that paperwork. Loved it, loved it. Then I took my very first sleep course. It was 11 years ago, and it was a Sleep Group Solutions course. So I take this course and my mind is blown. I'm like, oh my gosh, this is my new passion. Medical covers it. It brings it all together. We started implementing sleep and medical billing in all of our locations. So we had multiple locations, and we were doing this, and it was challenging. In fact, it took us 5 years to implement sleep into our first practice. Most practices will not do something that's going to take that long. You give up. It's hard. It's a battle. Your team is frustrated. The next new shiny thing comes along, and now you're implementing something different that maybe will be easier. So after we figured out how to do it, we decided we couldn't keep that secret to ourselves. It wasn't going to help enough patients. And so we actually sold all of our dental offices and started DevDent so that we could develop software and training solutions to help offices like yours implement these things without a 5-year curve. Okay. So that's who I am. That's why I do this. And that's my background. So why might an office or a dental office want to bill medical insurance? So these are some of my bullet points here, right? We know that if we can decrease patient portion, we can increase case acceptance. I don't think anyone in here would disagree that cost is a limiting factor for your patients to say yes to the care that you're recommending. So if we can tap into those medical benefits and we can decrease your patients out of pocket, more patients can afford the care you're recommending. Leave the dental benefits for future dental procedures. If you have a patient that needs something that could be medically covered, and we use all their dental benefits, they now have to start prioritizing their treatment plan based off of finances. How many of our patients have phase 1, 2, 3 through 10 treatment plans, and we're going through them $1,500 at a time because that's what their dental insurance is covering? I'm suggesting that we take those medical benefits, use those for medically necessary procedures, and leave those dental benefits for the class 2 fillings. Okay, that's where this works. Get paid for what you're doing. CBCT was a pretty good example. We don't need to have this conversation again, but there's probably many of you that are undercharging, not charging, or charging for panos when you do a cone beam. Caution against charging for panos. It's actually insurance fraud. You have to bill for the procedure you do. So if you are putting a pano on a ledger and you are audited, that is fraud. It is not what you did. But let's take it another step. How many PAs might you take during an endo procedure? You're going to probably take a PA before you start. You want to see the apex. You might take one mid or endo to check length. You might take one as a final x-ray. How many PAs are you charging your patient for? Chances are one or none, because dental insurance only allows so many x-rays a year. So we save those for hygiene and we don't charge them during endo. First of all, not to go into more fraud, because dentistry feels kind of scary right now. Like the conversation this morning, I'm like, okay, this is scary. So I don't want to go too far into fraud. But if you did a PA, it must be on your ledger. That's all there is to it. It doesn't matter if you're charging for it or not. If you provide the procedure and you are later audited by an insurance company or questioned by an attorney or a judge, and you took a PA that's not on a ledger, your documentation doesn't match your treatment. Okay. So again, not to go down the doom path again, but why aren't you paid for those 3 x-rays? Why? If you went to a facility, a hospital, and I had a damaged wrist and I said, I'm in pain. I think I might have a broken wrist. And they took an x-ray and they said, oh, sorry, Crystal, that x-ray doesn't show the doctor quite what they need. We need you to move your arm 25 degrees and we're going to take another x-ray. Would they charge me? Absolutely. In fact, they might charge me double for the second one because it took them more time. But in dentistry, we don't treat it that way. We don't charge for what we do. Medical insurance has no maximums for our scope. There are $1 million and $3 million maximums on some policies. If you get into a $1 million dental plan, please call me. Okay. Love to see what you're doing. It'd be really interesting, but there aren't the maximums. So that $1,500 that we're all tiptoeing around doesn't exist. They also don't have the same frequency limitations. How many of you think that an insurance company should be dictating how many x-rays or bite wings or PAs or prophies or perio maintenances you provide your patients? In what world does that insurance company know what the best course of treatment is? None. There is no world where that makes sense. Medical doesn't have those same limitations. There are a few things that they control, but honestly, you could take a cone beam every day on a patient if you could justify the medical necessity. Okay. Separate your practices from others. I already told you that example I have, but I had surgeons referring me patients. That is a pretty remarkable thing. They started to look at us as co-treatment and healthcare providers. And we really stood out in a very competitive space in Utah. So with those questions, why wouldn't you bill medical? Why aren't you? One, you might not have known you could, as Dr. Campbell mentioned, but you might be scared. It might be a liability concern. But we've heard today, you're already at liability for just being a dentist. You're at liability for providing the service. The payer that you bill doesn't increase your malpractice liability. Yes, you may be scrutinized by that particular payer, but I'm telling you, by billing medical, you are not opening a door to more lawsuits and litigation. You're already there, okay? The risk is there. So the reason you don't do it is because you don't know how. You're scared. It's too much paperwork. Maybe there's some resistance from your team. I spoke to a gentleman this morning who said, every course I've gone to on medical billing, I left not really knowing anything. They didn't leave with the detail. And I had to say, I'm sorry, that's probably how you're going to feel about this today as well. I don't have time in 1 hour to go over the codes and the details and the documentation. My purpose today is just to open your eyes to what the possibilities are and to show you some of the ways that it can be implemented into your practice. So what can you bill for? Probably the most common question. In fact, everyone who's come to my table so far has said, can I bill for this? Can I bill for this? Wait, what can I bill for? Oh, by the way, those taking pictures, if you go to our website and sign up for our newsletter, I will send you this entire slide presentation. So you can have these slides to share with your team. So at the end, I'll give you my website so you don't have to try to take pictures of all of these. I'm happy to share this information with you. But you can bill for everything: office visits, TMD, sleep appliances, all of your imaging. They don't have to be three-dimensional, right? Medical insurance pays for bite wings and PAs, panos. We can bill for oral surgery, perio treatment, anything related to trauma. So I've loved so far that everyone's kind of given you like this piece or this pearl to say, where do we start? If there is one place every single one of you should be billing medical, it's for accidents. It is the easiest to bill for. It has the highest level of case acceptance through that medical payer, and it has the biggest benefit to your patient. We've had accidents where patients come in and have $20,000, $30,000, $40,000 treatment plans because of some sort of injury. If you're billing dental only, they got $1,500. The rest is out of pocket. These are huge game changers for your patients. One of my favorite statements is when someone says, what can you bill for? I say everything, because it's not about the what you're doing. It's about the why you're doing it. Okay. So think about that. It's not about the procedure code. It's not about the fact that you're billing for an implant or billing for bone grafting. It's about why you're billing it. And can you prove medical necessity? I personally have billed medical insurance for a patient of ours who had veneers. There's nothing. In fact, we've even are questioning now if it's acceptable dental treatment. But if you billed for veneers, the diagnosis was long-term tetracycline use. I could show that a patient was taking a medication that caused a negative effect on the oral cavity, and they paid for the entire veneer case. So if I can get veneers paid, I truly mean everything, right? It's all about medical necessity. Can you prove that there is a correlation between the health condition and the oral cavity? These are my favorite 4 questions. Does the patient's oral condition or dental diagnosis affect health? Okay. Does what's going on in here translate to something else in the body? And this fake line that people have drawn across here to say these 2 items are not connected is wrong. Okay. Does this affect the rest of the body? Then, does the patient have a health condition or a medication that's having an effect on the oral cavity? That would be the tetracycline use. That could be dry mouth. Have you guys looked at the medications your patients are taking? You couldn't go one day without one of the top side effects of a particular medication is dry mouth. We're seeing the effects of this in the oral cavity. We're seeing these root surface caries. We're seeing the need for these class 5 fillings because of that. What about GERD, acid reflux? We're seeing the damage, the acid erosion to the oral cavity because of a medical condition, okay? Is there a lack of function? This might be something more congenital as well. This could be someone who has severe atrophy. This would be maybe some jaw or TMD conditions. This is a lack of ability to chew properly and natural function. And then lastly, are you screening for a medical condition? By definition, we just had to prove that there was a medical correlation. You better bet that if you are doing an oral cancer screening, that you are screening for a medical condition. Oral cancer is medical. Now, I'm not talking about stick your tongue out and say, ah, I'm talking about using a tool of some kind. If you're using a Velscope or a Vislite, an oral DNA, anything along those lines, you can actually bill medical insurance for those screeners. To try to make it more easy to understand and more organized, I have taken all of dental procedures and broken them into 6 categories for the purposes of medical billing. So every procedure you do fits into one of these 6 categories. Some things might fit into more than one, okay? So I'm gonna break them down. First category is exams and radiographs. One of the reasons I put this one first is because it's actually one of the easiest to bill for. So exams and radiographs take very, very little effort to bill. There's very few codes to choose from, and it's very easy to prove medical necessity. As I mentioned, they're paying for both 3D and 2D imaging. They're going to pay for your exams. So if you're seeing a patient for a medical reason, they will pay for your time. Just like Rebecca said, if you are seeing a patient, just like a medical doctor, they will pay you just like a medical doctor. So if you have a $25 copay to go see your primary care doctor or a specialist, you would have that same $25 copay to see a dentist. Maybe an example of that might be, maybe a patient was referred to you to get cleared for some sort of surgery. Maybe you've had these referrals where maybe they're eligible for a kidney transplant or something, and they need to have a dental clearance. Those things are covered by medical insurance, okay? Here, yes. Absolutely. So the question was, a patient comes in complaining of pain. There's signs of an abscess. It could be a significant pain. It could be as little pain. There's no concept of determining the severity. It's just, is there a medical condition? Would we all agree if we had pain anywhere else in our body that we would go to a medical doctor? If we have pain in the oral cavity, we go to our dental medical doctor. Medical insurance will cover that. Yes.
Hey folks, we had a question in the chat. The procedures you listed that could be billed under medical, do you need a pre-authorization for medical? Do you need to bill dental first? And if declined, then bill medical? How do you do this?
Great question. So the question is the order of billing. Do we bill medical, dental first, and is pre-authorization necessary? I'm going to get into this a little bit more detail, but I'll answer it now anyway. So I will always recommend you bill medical first. Medical has the higher deductible. So I want to bill medical first to eat up that deductible and to make sure I can prove that medical necessity. I can bill dental as a secondary, and they will coordinate benefits very similar to two dental insurances. It's not quite as smooth because we're transitioning from medical codes to dental codes. So there is a little bit more effort on our part, but often the dental benefit, let's say the $1,500, will satisfy the patient's medical deductible. So there is a possibility that between the two insurances, deductible is not even a concern at that point. Okay. Pre-authorization, to answer that question, is required on many procedures. So in dentistry, we often do pre-authorizations for our own peace of mind to know that there's a coverage there. In medical, they're required. So it's not optional. In fact, if you go out of order and you treat a patient for a procedure that required pre-authorization and you didn't do it pre-treatment by definition, they may not cover the service at all. Okay, so we do have to check on that. And I'll show you towards the end the protocol I recommend. Hopefully I answered your question. This is just a few examples. This particular procedure was billed for $250. The insurance allowed for this exam $124. This would have been equivalent to a limited exam in dentistry. The time it would have taken, the documentation, the difficulty of medical decision-making, $124. When is the last time you were paid $124 by dental insurance for a limited exam? No surprise, nobody raised their hand. So you can see though that the medical insurance only paid 84 of those dollars. The patient had a $40 copay. So you will have to get comfortable collecting copays from patients. That is part of this game. You want to be paid more by medical insurance, you may end up collecting a little more from your patient. Your patient probably would have paid nothing for that limited exam, right? They're probably covered at 100%, assuming they had benefits remaining, assuming they hadn't used them all. So you have to kind of weigh those options. Exactly to Dr. Campbell's point, we have all of those crossovers between limiteds, comprehensive, periodics, and there's all these limits. They're telling us how frequently we can see a patient. Doesn't matter the need, right? So radiographs are also one of my favorites to start with. Again, I mentioned they're quite easy to bill for. The coding is quite simple. These are just a list of reasons that they may cover radiographs. I am not suggesting that every bite wing and PA that you're doing tomorrow, or I guess you won't be seeing patients tomorrow, but next week be billed to medical. But if there is a medical correlation or one of these reasons, there's a great chance that they will be covered. Another reason I love billing radiographs to medical insurance is these things in red. Denied by dental. We are getting denials from dental insurance for radiographs. It's happening. Low allowables. If they do allow a cone beam, they're paying nothing. Super low. And then of course, those frequency limitations. I saw recently one of the major dental payers just updated their policy and they're going to allow panos every 10 years. They clearly have no value for what a pano is there for. Because if we're supposed to screen patients every 10 years for oral cancer, there is no value, okay? I do believe cone beam will be standard of care. I think it's coming. I think that dental insurance will probably pick up additional coverage for CBCTs at some point, but I do think those allowables are going to continue to be ridiculously low for the cost of the equipment that you're buying. Here's a cone beam example. This particular claim was a large claim. There's $11,000 allowed total, but they paid $251 on a cone beam. That's very average. Somewhere in the $200 to $400 range is what we expect to see on a cone beam. Here's another example. This is both a cone beam and an office visit. The provider charged $150 for the exam. The insurance allowed $125. The cone beam was billed at $600 and they allowed $580. Okay, so here's just some examples. One thing I want you to notice is the day of billed versus the date of paid. There is a perception that all medical insurance claims take forever. Raise of hands, how many of you have ever billed medical insurance? Okay, and I'd love an answer. Was it difficult? Do you do it daily, weekly, month? Terrible. Tell me why. Huh? Sure. You weren't ever taught how to do it? Everyone's blind leading the blind, right? Sure. No follow-up. Okay, perfect. Who else raised their hand? What experiences have you guys had with medical billing? Mhm. So it's just not something you're in a habit of doing, right? So it's not routine. And how about you? Sure. Mhm. Absolutely. So that concern was fee negotiation, and it's not uncommon for an insurance company to make you an offer. A medical insurance company will actually make you an offer, and they'll say in the fine print, "We'll pay you faster if you'll agree to our offer." And my suggestion is to put a big X through the middle of that form and send it right back to them, because my fee is my fee is my fee. And it's what I'm entitled to be compensated for the service I provided. And no one else gets to tell you different. Okay. Mhm. Absolutely. And that is where a company like mine will come in and help, because we will take those fee negotiations off your hands. You tell us what your parameters are, and you say, I'm willing to take a 10% discount as my maximum discount. We put that in, and we will actually respond to those fees for you. Mhm. Absolutely. Again, that's another problem. We're seeing it a little bit more with dental than medical, because the medical providers have a little bit more control over that industry. So they're saying no, and the payers respond. Dentistry, I don't know if you guys are familiar with what she's referring to, but if you guys gotten those, they're not even cards. They just give you a number, and they can be so easily lost. And you're wondering where your payment is. Nothing matches. And you find out that they sent you an electronic payment that you have to run through your credit card processor. It's very frustrating. It doesn't work with our flow. We feel frustrated because we missed them. I've literally found them filed away, and the card never got ran. We never even posted yep. They're banking on that. Not to mention, to her point, they probably own the credit card company and are charging that 3% fee to you. So they're keeping 3% of every reimbursement, right? Absolutely. So there isn't as much of a problem on the medical side with that as there is the dental side, but we do have a few solutions, just like you mentioned. There is a way to get out of those, so we can help you with that as well. Okay, second category is screening and diagnostic. This is also one of the maybe more exciting ones for some people. This is where our perio comes in. We are actually getting medical insurance to cover scaling and root planing if we can prove a medical correlation. Now, that is probably comical. That statement right there should make you all just scratch your heads, because we know periodontal disease is affecting the entire body. We know it's a medical condition. Unfortunately, the medical insurance companies and their directors don't have the same philosophy. So when we get those covered, the easiest is when there's a comorbidity. Patient is pregnant. Patient has a heart condition, patient is diabetic. Those are the type of situations where we get a more easily paid medical claim. They are not just paying for the scaling and root planing. They are paying for the perio maintenances. They are paying for their Reston. They're paying for the laser treatments. We have amazing results with LANAP procedures if you guys are doing any advanced laser procedures. So there is coverage there. I mentioned the screenings initially. So this is where your oral cancer screenings, your pH testing, your A1C testing, any of those ancillary services. I had the pleasure of speaking with a doctor earlier who is really approaching as a total health practice, right? The perspective is we affect everything. These are the types of services that will be covered. Botox, if any of you are doing Botox for the treatment of headaches or TMD issues, medical insurance is actually paying quite well for Botox. So, and actually it's not too challenging to bill. Here's a couple of EOBs. This particular one just is an exam, a scaling and root planing and an X-ray. And after the co-insurance, they paid $568, right? These will be higher than your PPO fees, and I'll get into fees in just a little bit. Here's another one. This is a scaling root plane for $1,100, and they paid $720. Now, to my point earlier, this will likely cost the patient more money to go medical than dental, because scaling and root planing would have likely been covered at 80%, depending on the policy. Even if it was 50%, it would have been your PPO contracted fees, and your patient's copay could actually be less billing dental. But how many times do we see 4 quads of scaling and root planing eat up almost the patient's entire dental benefits? And now they're postponing their restorative treatment and their other treatment, that if we switched that around and billed medical for the scaling and root planing, they would have the advantage of both insurances and getting more treatment, okay? Perio maintenance is covered as well, so we definitely want to take that into consideration. They don't give us those same restrictions on frequencies and quantities. If we can prove that the patient maybe has Parkinson's disease and doesn't have as good home care, we've had insurances company allow perio maintenances every 30 days. Why wouldn't they? If you as the clinician says that that patient cannot keep their oral cavity clean without the assistance of a hygienist, why wouldn't that be covered at whatever frequency you recommend? And $182 for perio maintenance is considerably higher than what you guys are being reimbursed today. Sleep and TMD. Super, super passionate about this topic. I can't even go into it much because that's not what I'm here for, but Rebecca did a fantastic job. Sleep appliances are covered by medical. TMD appliances are covered by medical. So we do have an opportunity to take what can be very expensive procedures and really help our patients afford the care by lowering their out-of-pocket costs. I'm going to go into that in a little bit more detail, but not a lot. But habit correcting devices, if any of you guys are interested in the pediatric airway process or palatal expansion, anybody in here doing advanced ortho, there is medical insurance coverage even for clear aligners. Okay, so there is an opportunity. Again, it's because it's not about the what, it's about the why. Why does this patient need it? Is it just to straighten teeth? And I don't mean that to say it that way. It's never just, but is the purpose to have straighter teeth, or is there more going on? Was there some sort of malformation or something that happened that they need to have corrected? Again, the ADA made a statement in 2017, and I'm curious if we think there's going to be a liability at some time in the future, because if there is a liability for not identifying that a tooth needed endo, and so we took an X-ray, we didn't see it, maybe we saw it, but we didn't think it yet needed endo, maybe we missed it entirely. Yes. Okay, that's a great question. So he said, as soon as it appears on the curriculum at dental schools, you will be liable for it. It's coming. Understand, this will no longer be an option in that case. We are already teaching at multiple dental schools. I'm teaching at U of P. I teach at University of Utah. It is coming. So with that being said, it was initially a recommendation that you screen. And to that point, now it's going to become a liability if you don't, okay? So that's actually fantastic for someone like me who thinks every dentist should be screening for it. So I'm very excited that there's going to be a little bit of pressure to do this. I'm not saying you all need to treat it. It might not fit into your wheelhouse. It may not be your specialty, but that's no different than endo. Everyone in here probably doesn't do endo and third molars, or maybe you don't do the more complicated ones. You identify them and you refer. That's all anyone's asking you to do with a sleep appliance is identify and then refer, or a sleep patient, excuse me. Also, I was thinking a little bit about the documentation, and I feel like this comes in very strongly from a liability perspective. You are going to need to incorporate the documentation into your hygiene and new patient appointments to show what steps you took to screen a patient and what steps you recommended for that patient. It's going to be important. Carry the coffin. I call what I refer to as share liability. If I have a patient in my chair that has a medical condition that we've somehow been involved in identifying, I want to tell every physician they see. Because as soon as I send that letter to let them know that they've been diagnosed with a sleep disorder, I shared liability. I am no longer the only person who knows this patient has sleep apnea. So if you are treating sleep, be very, very careful about keeping that in your chart notes only. You want to tell any physician that that patient has a record with that they have this disease. Shared liability. Yes. Okay, perfect.
We have a couple of questions from online. The first of which is 0367 in specific, both jaw imaging. I'm not sure what the question was there.
I'm not either.
Okay, we'll overrun that. The next one is, do we write a narrative at the time of pre-authorization for medical necessity of periodontal procedures for approval? How do you prove that this is a medical necessity? Do you team up with their medical doctor or ask the MD?
Great question. So the question is, how do we prove medical necessity? This question was specifically to periodontal disease, but this will be true for any medical procedure. You are not licensed to diagnose diabetes or pregnancy. You are not licensed to diagnose sleep apnea. You have to stay within the scope of your license. And I guarantee from a liability perspective, that is one of the biggest concerns. When you need to use a comorbidity, let's say we're talking about a perio patient who's pregnant. You wouldn't believe the list of codes to choose from for a pregnancy. It's literally, is it their first pregnancy or fifth pregnancy? Have they ever had a miscarriage? What trimester are they in? Are they high risk? Are they over 40? Is all in the code. So it's remarkably difficult. You call their OB. You say, I've got a patient of yours here in my office who is needing treatment for periodontal disease. I believe that this could affect the baby, and I need to get a code for their pregnancy. They will read it right over the phone. All you have to do is put in your clinical notes, spoke to Nurse Nancy from Dr. Smith's office. She provided me this ICD-10 code for pregnancy. That's it. I don't need it in writing. I don't need them to write a lengthy referral. And that's important because if we were dependent on these medical doctors to provide this to us, we would be waiting a long time. So, but guess what? Their medical records and their nurses will answer these phone calls. They will respond and they will give you the codes. So be very, very careful to stay within your lane when it comes to diagnosing. So use those diagnoses with the support of your local physicians. Yes.
And our last online question is, we don't know how to write a narrative. Help.
Oh my goodness, we don't know how to write a narrative. Help. This is my favorite thing. If we could sit here for the next 3 hours, you guys would be like masters in clinical note taking. So I do have a slide towards the end of my presentation showing you the SOAP note format that I recommend. If I do not answer your question thoroughly, I have a 1-hour webinar that is free on my website. Go watch it. I break down the clinical chart requirements for medical insurance in probably a detail far beyond what any of you want. So it is there for you. Okay, I'm gonna get back to sleep. Kind of. So poor sleep affects the entire body. We have covered that. This is why I'm so passionate about it. I think it's really important to understand that without dentistry, these patients are going to continue to be undiagnosed. When is the last time you have gone to your medical doctor and they have asked you about your total health? And if you do have that experience, I'd like to know who your physician is because there aren't very many of them. You go in for acute illness. They treat you for your sinus infection. They treat you for your sprained ankle. They treat you for what you're there for. They are not asking you how you're sleeping. And even if they do, they prescribe you Ambien. That is what the protocol is. We can be better than that. We as dentistry can be preventative. We can catch these patients earlier and we can change their lives. And I have the pleasure of seeing this every single day. This is the workflow that we teach. I just wanted to touch really, really quickly on the screening component. And it's not an old man overweight disease anymore. 20 years ago, it was considered only old, overweight men had sleep apnea. You had to be overweight and you had to be old. I have moderate or stage 2 sleep apnea. I'm not male, I'm not overweight, and I'm not old, but I've had this disease for about 10 years. So by the time I was 30, I was already diagnosed with sleep apnea. Had I not intervened, had I not been treated, who knows where I would be today? Who knows how progressive this disease would have moved for me? I actually could be those 30-year-old men who are gone. That could be me. The only reason I was diagnosed was because of dentistry. No healthcare physician in this country would have sat me in their office and said to me while I'm there for my sinus infection, Crystal, how are you sleeping? Do you snore? Do you ever have daytime tiredness? Do you have never going to happen. Here is the required documentation for an oral appliance. So you can not bill insurance unless you have a sleep study, period. That is a required document. So the very first thing we do is we get a sleep study taken, and it can be an in-lab study or it can be a home study depending on the state you practice in and depending on the insurance company you're billing. And what I mean by that is there are different protocols for payers like Medicare, Medicaid, and TRICARE. So if you're working with federal plans, there are some slightly different rules you need to understand, but it must be interpreted by a board-certified specialist. Your general doctor that you see routinely cannot diagnose sleep apnea. Only a board-certified specialist can. Now, any MD can write the prescription to you to treat. So any MD can say, here, Dr. Smith, please provide this patient with an oral appliance. So we get the sleep test with the interpretation. We get the prescription from an MD. We have a patient sign a CPAP affidavit, and we have detailed clinical chart notes. Those are the 4 documents that you must have in order to bill medical insurance for a sleep appliance. Pre-authorization is nearly always required. Okay, not always, nearly always required. So that does take about 2 weeks to get an approved pre-authorization back. They are requiring those to still be submitted in paper format. So there is a nice little delay due to that, but we can get those pre-authorizations back in about 2 weeks. Yes. Okay, so the question was, what's the limitation for medical payers paying because you're a non-participating or out-of-network provider? It depends. So in another course, I would actually break down the 5 or 6 different types of insurance from HMO to PPO to EPO to Medicare, Medicaid. But in a short story, HMO plans means that most of them require you to be a participating provider for you to bill. So we have some pretty major HMO plans like Kaiser. If you ever spending time in California or Seattle, Kaiser is a huge HMO in these areas. Kaiser is like its own little world. They have their own rules, they do their own things. We have still been able to get coverage even through HMO plans like Kaiser if you fill out the right paperwork. It's just about the paperwork. There's something called gap exception. This is probably a little bit too deep, but gap exception is where we ask an insurance company that we're not participating with to give us a one-time exception to be considered in-network for that patient, just one time. Gap exceptions, when they're allowed, are often approved. And what they're saying is there's no other dentist in this area that is participating that provides sleep appliances. So if we can prove that there's no coverage available in network, then we can get them to kind of relax that rule, if you will. Now, I would not suggest that you all go out and participate with medical plans. It is my recommendation you stay out of network until you determine you need to go in network. And the only way to do that is get a little bit of history with your local payers and see which of them don't cover you if you're out of network. See what your major payers are in your area. There's no reason to go out and contract with an insurance company that maybe you only see come through your door once every couple months. So we have an entire process of doing an insurance analysis where we have you collect copies of your insurance cards, and we will help you determine if there are plans you should participate with. Okay, sleep appliances. There is a pretty big swing in allowables. So you can go to some courses and people will tell you you should charge $10,000 for a sleep appliance. That is not my suggestion, but it's just because it's my opinion. And I'm a pretty opinionated person, I've found, because I have an opinion on most everything. I don't think you should charge $10,000 for a sleep appliance. I don't think they're worth it. Yes, I think they change lives. Yes, I think they're incredibly valuable. But if you charge $10,000, your patient's expectation is here. You almost can't make them happy. Right? It's just too expensive. They are going to expect every symptom they've ever had to go away. They're going to expect it to make them thinner and prettier and smarter. I mean, that's what the expectation is of $10,000. So we want to charge a fee, one that's reasonable, but also that our patients can afford. If you do all of this work to implement sleep into your practice and you charge more than anyone can afford, you've done this all for nothing. Okay. This particular practice that uses us as a billing company billed $5,000. They allowed $3,500 and they paid the provider $2,975. You will be an out-of-network provider, so you can balance bill your patient up to the $5,000. So you can say, I want $5,000 for every sleep appliance I do. That's the value. Whatever insurance pays, and the patient's responsible for the difference. Because you're out of network, you have that flexibility. Notice the turnaround time. That claim was paid in less than 30 days. Okay. No, I will not guarantee all claims will be paid within 30 days. But what I can tell you is if you've done the credentialing right, you've done the paperwork, and you have your boxes checked, our average claim time is less than 30 days. Okay. It's funny, I get a lot of feedback. I would treat sleep, but medical's never paying. I tried and it's so challenging. Sleep appliances are easier to bill for than accidents. They are the easiest procedure. The only thing you have to have is the paperwork. The coding is so simple. There's 2 codes to choose from. I mean, it's so simple, but you have to have the documentation. And here's another sleep appliance around $4,000. Now, I keep this in my presentation. It's an old EOB, but this office insists on billing $8,000 for every appliance. What I really find frustrating in our industry is companies like mine will put an EOB up like this, and they will say, this is what you can get paid. And it's the 1 out of 100, 1 out of 500 that pay this well. So this particular insurance company allowed $7,200 for a sleep appliance. But I'm here to tell you that is not normal. And I'm not going to put this EOB up here and tell you all to expect that. What I don't understand is why people would do that, because then you're just disappointed. You're just frustrated and mad at me. So really, honestly, I think you should be charging between $3,000 and $5,000 at the high end. If you really want to help patients and get case acceptance, I think it's reasonable to charge $2,500 for a sleep appliance. The lab bill on most of these will be about $300. Yes. You have to collect whatever amount is allowed by the insurance. So if you bill $5,000, the question was, do you have to collect the difference? Do you have to collect the billed amount, or can you make an adjustment? So the answer is you have to bill whatever they allow. So if you bill $5,000 and your insurance company comes back and says, we allow $3,000, but we're only paying $2,000. You must collect up to the $3,000. You can choose to adjust the difference between your full fee and the allowable amount. You have to be cautious, though. You cannot favor particular payers. You cannot favor particular patients. So whatever your policy is, the statement I will make forever, your fee is your fee is your fee. Set a fee that you want to be paid, and that is what your expectation is. That is my suggestion. You will stay out of trouble if you do it that way. Here's another example. This is a perfect example. The office charged $6,500 and the insurance only allowed $1,950. Now they paid $1,850. So in their mind, they paid really, really well. They only had $100 co-insurance for this patient, but the provider wanted $6,500. Right? That was the amount they billed. So the provider would have the decision to make how much between $6,500 and $1,950 they want to adjust. You cannot adjust the $100 coinsurance. Adjusting deductibles and adjusting coinsurance is insurance fraud. It is the fastest way to get fined. Okay, it's the biggest mistake being made. TMD appliances are absolutely being covered. This is a pretty high allowable. They allowed $4,000. They allowed $39.95 for a TMD appliance. That's on the high side. Okay. Here's another one. $3,500 was allowed. They paid $2,346. When's the last time dental insurance paid you $2,300 for any procedure? Oh, they won't, because there's a $1,500 per year maximum on most plans, right? So this one procedure would be enough to justify billing medical insurance. And here's another example of one of my fine offices who insists on charging $10,000 for a TMD appliance. As a billing company, we will charge whatever you tell us you would like to charge. That's not our decision to make. I will coach you and give you some suggestions, and you can clearly tell by my reaction, I think 10,000 is a little high for a TMD appliance. Trauma, again, where you should all start. It's the easiest to bill for. My favorite thing about trauma is it covers everything. If they approve the claim, they will cover the exam, the x-rays, the extraction, the membrane, the graft, the sinus augmentation, because the tooth that they lost was an upper that had never had an implant before, and it would be into the floor of the sinus. I mean, it doesn't matter that the accident didn't involve the sinus. What matters is we had to restore that patient back to pre-accident state. And if the tooth is not savable and implant's the ideal treatment option, they will pay. They'll even pay for a flipper if it's an anterior tooth and we need to wait for osseointegration. The internal bleaching. I've seen them pay for everything related to an accident. Yes. Oh. There is not occlusal trauma. Great question. Question is, what's an accident? Is it defined by a specific type of trauma or a particular time frame? Well, one, there is no statute of limitation on a dental accident. So if the accident happened 20 years ago and the patient recollects in enough detail exactly what happened, and you as the clinician believe that the damage to the oral cavity is consistent with the accident report, you have a dental accident. Okay. We are going to limit ourselves on occlusal trauma. It will not be while chewing or eating unless it's a virgin tooth. If you have a completely natural, untouched tooth that breaks while eating, that's an accident. That is not a failed restoration. That is not due to caries. That is none of these things. Okay. Best thing about accidents, we don't have to involve an MD. We don't need a police report. We don't need an ER report. We don't need a witness. We don't need any of those things. We have our patient fill out an accident form that clearly describes the detail of what happened. We then, excuse me, I'm not a dentist. You then determine clinically if you concur. If you do, we have an accident. Okay. If you would like this accident form, it is available on my website as well. And it's a free resource that we provide. And it's a fillable PDF, makes it pretty slick. Okay. Great question. So question is, if you are in network with a particular dental plan that also has a medical plan, are you automatically in network with the medical side? And the question is, it depends on the payer. It's like my favorite non-answer answer ever. So about half of the payers automatically move you in network with medical when you start billing medical, but you can change that if you want to. It does take some credentialing and a phone call and some paperwork, but you can choose to be in network with dental and out of network with medical with the same plan in most cases. Okay. Also along those lines, most medical plans do offer contracts to dentists. So if you want to participate, in most cases, it is an option. Surgical, and I'm running a little behind, so I'm going to speed up, which I've already talking so fast. So laser and surgical procedures. This is probably the one you guys most associate with medical billing. These are your extractions, your implants, your oral surgery, your full mouth reconstructions. This is probably what gets you kind of more excited about it. One reason that this is so popular, these are generally expensive procedures. And the more expensive the procedure, the more beneficial medical billing is for case acceptance. That's just a fact. Full mouth reconstruction, all on 4 or implant supported dentures, they are covering these procedures if we're doing them for a medical reason. Here's an example of an implant. They allowed $2,350. They paid $1,760. If you want to charge $5,000 for an implant, you still can. But those of you that are PPO contracted probably aren't getting $2,300 as an allowable amount for an implant, I would assume. Another example, this is an implant, a graft. They paid $2,580. That's $2,580 that your patient didn't have to pay you, right? That's the benefit. This is just a bone graft. This is interesting. We're starting to see bone graft allowables go up and up and up. I'm seeing even $2,500 per site, not even per quadrant, We are seeing $2,000+ for a single site of bone, which is really high in my opinion, because I know what we pay for bone. This is one of my favorites, and this might be why you've thought of medical billing in the past. This is a third molar extraction. Raise of hands, how many of you have billed dental insurance and had a denial that says you must bill medical first? Raise of hands, who's experiencing that? Oh, less than a quarter. So if not a lot of you, it's happening, it's coming, it's going to come more. Okay. And it's because dental insurance is trying to minimize their reimbursement. So they're saying, hey, we think completely bony impacted wisdom teeth are medical. But guess what? Good news, medical saying they're medical too. So it's not like we're in this like holding pattern. We can get coverage. Perfect example, $2,159 for wisdom teeth extractions with IV sedation, denied by dental, said bill medical, billed medical, they paid 100%. We just saved this patient $2,100 and left all of their dental benefits for their next phase of treatment. As a general practice, we always hated referring patients for third molars early in the year because they would use their entire dental maximum at that oral surgeon's practice. And then we were trying to convince them to move forward with their treatment without benefits. Last category is systemically related. This is the most rewarding. It is the most challenging. This one requires the participation of a medical doctor in most circumstances. What this is saying that the patient has that health condition, that medication. Maybe they have all kinds of things, the diabetes, they have the GERD, they have some sort of immune disorder, something that we believe is affecting the oral cavity. But in this category, you're almost always going to have to get a medical doctor to give you that code. You can't do these ones alone. I share this story often. This is one of our favorite scenarios. I have many like this. This patient was in high school when she was first seen. She suffers from amelogenesis imperfecta. Her teeth were falling out in her hand. She was on suicide watch. You can imagine for just a second how hard it is to be in high school anyway. Add the fact that you don't have teeth to the equation. She was in trouble. She came to one of our offices, not mine, but a company practice we work with, and needed a full mouth reconstruction. Her only treatment option was implant supported dentures. Her family could not afford the care. We were able to get insurance to pay for 100%. My challenge to each of you is if you could help one patient in the entire lifetime of your practice do this, it's worth it. But imagine if you knew what to look for, if you could find a patient like this a month, right? These patients need us. We've even helped entire families get restorative dentistry done through medical insurance by doing this. Yes, doctor. So the question was, does the medical insurance give you the option of billing for or choosing the treatment that you think is ideal, or are they limiting you to the least expensive? And the answer is they give you way more treatment choices than dental. Some payers will put a cap on, and they'll say minimum treatment could have cost $2,000. You're billing $50,000. We're going to cap it at $25,000. So they could put a cap on, but I've not seen them actually dictate that we can't use the implants for support ever. And I've probably personally, hands-on claims, probably billed for 75 or 80 implant-supported dentures with no issue. Okay, great questions. Okay, full mouth reconstruction. Here's one. They allowed $23,000. They paid $21,000. That is $21,000 that your patient did not have to pay. You all can see that your patients would accept these large cases much easier if there was the possibility of having a benefit like this. So as I finish, the medical billing process it's not that complicated, but it's different. And I think the point that was made earlier, it's just not what you're used to. It's not part of your everyday flow. You don't have practices and protocols in place. That would be the same if you were trying to add anything new to your dental office. If you didn't have the protocols in place, you will struggle. This is the way we do it. I'm simplifying a fairly complicated process, but we go down these steps. We get the insurance. We contact the insurance to see what benefits are available. We do the pre-authorization if it's required. We then present patient benefits off of those estimates. If the patient says yes to treatment, we complete and we bill the claim when the procedure is complete. Never, ever, ever do we bill medical insurance when a procedure has begun. It is when the code in its entirety has been finished. And again, when we talk about liability and fraud protection and all of these things we've talked about today, that is a critical piece. You get audited and you billed for a procedure that was not complete. They not only will fine you, they will take the money back and they will open up your charts and look at everything they want to. Okay. And again, we're not perfect. Okay, perfect. Credentialing versus contracting. This is a confusing topic because we don't use the word credentialing in dentistry all that much, but credentialing is just letting the medical insurance know that you are a provider that's going to bill medical. That's it. Here I am, I'm a dentist, and I'm going to start submitting medical billing claims to you. That's it. You're just telling them who you are. They need to verify your tax ID, that this registration with the state matches the tax ID, that matches your license, that matches your DEA, that matches your malpractice. They just want to see that everything looks right. If you do not credential correctly, you will not have success. There is no way around it. It is the single biggest reason for delayed or denied claims. Contracting, of course, is where we choose to participate and be a participating provider. We sign an agreement, we agree to their fees, we agree to their terms. You can do both, but you must credential to be successful. We do have a resource on our website. One of the major national credentialing databases is called CAQH. It's CAQH. We have a webinar that walks you through step by step how to do this credentialing. We have a fillable checklist, but we also provide this as a service. So if you would like to have your handheld or have us do this for you, it is an option. I mentioned briefly the SOAP note concept. I am about out of time, so I would recommend that you look at that free resource I have on my website where I in detail break down what an SOAP means. I would encourage you, and I think everyone in this room that's been talking about liability, if you had a SOAP note format for every encounter you have with a patient, you will make it much more difficult for these patients and attorneys to actually win these arguments. Because all those points that were made earlier, why'd you take a radiograph? What did you see? What was the diagnosis? If you follow this SOAP note format, you can't move on until you've answered all those questions. So as far as protection from liability, I think clinical chart notes are one of the most important things you need to do. Yes, doctor. Mm-hmm. Mm-hmm. So that's a great point. So the comment is there's definitely some regulations coming that are going to punish you if your notes aren't more custom, right? If we're just auto click and all you're doing is changing shade on every patient, or you're changing the number of carps you used for that anesthetic, and that's the only thing you changed, and they look at your charts, they're going to say, these aren't charts. One of the cool things about the templates that we create is they're not like that. They actually pull in the patient's own medical history. They pull in the patient's own radiographic findings. It is about 75% custom per patient. So we're going to make sure that we're on the right side of that argument every time. So great point. We all have to use auto notes. If we didn't use auto notes, we would probably not take notes at all, to be honest. An auto note is still better than no note. So definitely don't give them up, but do really spend the time to ask, have you changed at least 25% of that auto note? And 25% has been in past. I don't know if you've heard the same, but 25% in past has been the threshold. Okay. As I finish up, I asked these questions. Okay. I asked, why would you bill medical insurance? Now I'm asking you, is medical billing right for you? Would more patients say yes to the treatment you recommend if you were offering this service? And I believe the answer is yes for all of you. Our big cases walking out your door. Do you have cases that are large and expensive that you can't get accepted because of cost alone? Are you writing off or not charging for services? And I know the answer is yes to every single one of these. Are you contracted fees lower than you would like? If you hate doing dentures and your PPO fees on dentures are so low, they might be a procedure that you choose to bill to medical insurance. You can bill your full UCR fee for service fee. You are not subject to those PPO fees. And do you want to separate your practices from others? And if you want to do those things and help more patients get the care you're recommending, I think medical billing is a fantastic avenue to help you with that. Our company has a couple different divisions. As I mentioned, DevDent is a company as education, on-site team training. We offer services where we come to you and teach you and train you and help you create your custom notes. You can come to our courses and we can train you in an audience like this. We also have a sleep software, which will actually help manage the sleep practice within your practice. So it is currently our products are Dentrix connected, and later in Q2, they will also be connected with Open Dental, EagleSoft, and Dentrix Enterprise. So there's some real integration coming. We just partnered with Henry Schein Dental and Henry Schein One, and we are their exclusive medical billing partner. So we're very honored to be chosen for that. We have webinars every month. These are fantastic ways to just kind of dip your toe in. As all of you are dentists, or most of you are dentists, you can't really go back and do this without your team. And you probably know that about most things in dentistry. Your team has to be on board. So you could have them watch any one of these webinars, whether it be one that's scheduled upcoming, or whether it's some of our hundreds of on-demand webinars. The one I'm doing on March 16th is a fantastic intro webinar. It's very much like this. So if your team, you just wanted to take back and say, hey, I just want to see what you think about this or get some feedback, that would be a great one to start. Super excited to be doing a course with Dr. Campbell in May. It's really the first of its kind. We're actually bringing a 2-day course for dental and medical billing in one place. So you're going to get to hear from him in just a minute and his expertise. And if you decide to join us in Atlanta, you're going to get 2 days of the details. I'm actually condensing my 2-day medical billing course into 1 day so that you can get everything you need to really understand the process. As I mentioned, I didn't give you codes today because I don't have time. This next course, you get the codes, you get the documentation, you get the rules. That will be where the detail comes. If you want any more information about my company, if you want to schedule these webinars or sign up for Dr. Campbell and I's course, all of these things are done at our website, which is just devdent.com. There's also a link. Someone in the audience had asked me earlier, I just want to talk more. Like they just wanted to pick my brain. We have a link on our website that says talk to an expert, and you just get links directly to our calendars, and you can schedule a 30-minute window just to pick our brain. Is medical billing right for you? Is sleep medicine right for you? You have concerns or questions. Maybe your office manager has some bad experience with medical billing and you want her to speak with me or he. Those are those options. Here's my contact information. You can reach me at support@devdent.com. There's our phone number. We do have a free Facebook group. It's fantastic. There's about 5,000 active members. It's a really active site. It's medical billing for dental practices. I strongly encourage you just to join. You can ask questions. They can be answered both by our team as well as other dentists, other office managers. People in your area can share real life experience. I love the point earlier that was made. We are supposed to be collaborating, not competing. And that's what this Facebook group is really all about, is how can we collaborate to provide the care we want and the best lives we can. So open it up really quickly for questions. I did go over, so I'm sorry, but does anybody have any questions for me before I turn it over to Dr. Campbell? Yes. Mm-hmm. Absolutely. So the question was, how do we handle potentially high medical deductibles? So one, I would have you look more closely at your medical policies before you assume they're high. And I only say that because I have thousands and thousands and thousands of claims a month come through our software, and the deductibles aren't as high as we used to think, okay? We have seen a real, that's one huge benefit of the exchange, is we're seeing lower deductibles. However, if there is a deductible to be met, the patient has to pay the deductible. That's the plan they chose. So it's really important that we realize that patients who have high deductibles are paying lower premiums. or are on a group plan and that was all that was available, but it was the plan that they chose. So it's just a very candid, straightforward conversation. Here's your treatment plan. It's a $5,000 treatment plan. However, you have a $5,000 deductible. I can bill your medical insurance as a courtesy and you will have satisfied all $5,000 of your deductible, or you can just write me a check for $5,000. Every patient would rather have their medical deductible satisfied while they write you the check than just write you the check, because now for the rest of the year, their deductible will be met. Also, a lot of the patients we see, especially from a sleep apnea perspective, are not always the most healthy. And we see that they satisfy their deductibles very, very quickly. It is actually statistically that a patient with diabetes will meet their deductible by the end of February. That's how expensive diabetic treatment is. So there was another question. Yes. Nope, not quite. So the question was, how do we handle it where we can't bill until the entire procedure is complete? And there's this unknown variable of allowables and fees. That is true to some extent, but in a procedure like that, I'm going to have a pre-authorization. So I'm going to pre-authorize it before I ever even touch a tooth. Okay. And I'm going to pre-authorize most things unless they're emergencies. So I'm going to pre-authorize, and now I'm going to have some confidence when it comes back that at least I know it's a medically necessary procedure. They've approved the procedure. I know their deductible in advance and I know their co-insurance in advance. So I can make a pretty reasonable estimate, not to the accuracy you can with dental. With dental insurance plans, you have their fee schedules. I would imagine your team can estimate dental portions within a 2% accuracy or less. I mean, you could probably get it to the penny. We won't have that same level of confidence. So we're going to say we bill as a courtesy. We're going to set the patient up to pay at least 50% of a major procedure like that. And we have a whole formula we use that I can share and teach you. So great question.